everyone. We're going to give attendees a couple more minutes to join, and then we'll get started. Thank you.
Okay, it is now 11:33 a.m. Good morning, welcome, and thanks for joining us today. This is Brian Waterman. I'm the Vice President of Analytic Business Solutions for HealthCurve Analytics. For those of you who aren't fully acquainted with HealthCurve Analytics, we're a subsidiary of Missouri Hospital Association that was established to deliver next-generation analytics that position our member hospitals and health systems for future success in emerging areas like value-based payment and basically new evolving technologies in healthcare and payment models. In addition to leveraging data, analytic, and research capabilities built on MHA and Hospital Industry Data Institute experience and assets, HealthCurve seeks to establish alliance partnerships with select solution providers that we feel can offer superior solution depth and value in key emerging areas at a competitive price to our member hospitals and system. Earlier this summer, HealthCurve entered into one of these partnerships with the Spectrumetics organization to support member efforts with MIPS and advanced alternative payment model tracks of the MACRA program. MHA and HealthCurve recognize the strategic importance of member initiatives to implement MIPS and APM programs and chose Spectrumetics based on their experience combining clinical and billing data across health systems to power quality improvement initiatives, the capabilities that they have in their eMeasures 360 platform that we'll be talking about a little bit more today, and the expertise of their MIPS team. Today, I'm pleased to host Dr. Laj Lockenpaul, Mr. Mark Bryant, and Mr. Nathan Brown from Spectrumetics to share key aspects of their solutions related to MIPS and advanced alternative payment models. Dr. Lockenpaul is the Chief Executive Officer of Spectrumetics. In tandem with his role at Spectrumetics, Dr. Lockenpaul is an active member of the National HIMSS Clinical and Business Intelligence Committee, serves on the governance board for Medicaid's Information Technology Architecture, and is a member of the Board of Trustees for the University of the Sciences. Dr. Lockenpaul's co-panelist, Mr. Mark Bryant, is the National Director of Sales for Spectrumetics and is responsible for both new business development and client relations. Prior to joining Spectrumetics, Mark was Senior Account Executive at Sun Microsystems and at Iron Mountain. I'm now going to hand things off to Mr. Nathan Brown, who will be facilitating the remainder of today's session.
Okay, thank you, Brian. So I'm Nathan Brown. I'm Director of Marketing for Spectrumetics. I'm going to be the moderator for the webinar today. Run down the agenda quickly. We're going to do introductions, which we've already done, give a little bit of background on us, Spectrumetics, then dive into the MACRA program, specifically the key components of the MIPS track and the APM track. And then finally, we'll talk a little bit about the Spectrumetics eMeasures 360 platform and how it provides solutions for MIPS and APM reporting. So without further ado, I'm sorry. Couple quick housekeeping things. We will be sending out an ebook of the webinar after the webinar to everyone who is attending today. If you have any questions during the webinar, please feel free to ask them. Just enter them into the questions section of your control panel. And then finally, we're going to be conducting 2 polls during the webinar. So if you could please take a moment to answer them, we would appreciate it. And with that said, without further ado, I'm going to hand it over to Dr. Lockenthal.
Hello, everyone. Good morning and good afternoon to those on the East Coast. It's a pleasure to present to you. My name is Raj Lockenthal, and I will be talking about what we do as a company and also a little bit about MIPS and MACRA. First of all, very, very excited about our partnership with HealthCurve. We inked that maybe a couple of weeks back, and thank you, Brian, for spearheading the effort with Teresa Rourke and Steve on the phone as well, Steve Warchall, for actively participating in it. Really appreciate it. Want to make sure it's a rewarding relationship for both the teams. So about Spectrumetics, as a company, we're 9 years old. Our mission is to assist our clients in transitioning to value-based care. That's all we do. And part of that is obviously the MIPS and the MACRA programs. And we do that with 3 core competencies, and we'll be talking about them, how they relate to MIPS and MACRA in the coming slides. So the first competency is our ability to aggregate data, to normalize it, harmonize it, and populate an enterprise data warehouse from where different analytics activities can be performed. Then calculate and report on all MIPS and MACRA measures. So measures, calculation, and regulatory reporting, especially as we take out data from EMRs. And then financial profiling and risk modeling and population health. In our current presentation, it will be relevant around cost analytics that the hospitals or the health systems will need to report on. Now, some of our clients, this is not the entire client list. So recently, we've been very active in the Northeast. So that's has been our area of focus or competence. So so for MIPS clients, some of our clients are University of Rochester Medical Center, a large health system with 2,400 providers that will be working with them to help them transition to improve their MIPS scores. And I want to take a minute to talk about them. So there is talk about the proposed rule for 2018, and URMC said we don't really care about that. Our intent is to improve the quality of care we deliver by our providers, and especially as we transition to value-based care. So they're looking at the MIPS measures and the MIPS scores, not only for MIPS, but they're also looking for that for a clinically integrated network. They are a clinically integrated network that derives millions of dollars from health plans for delivering a certain level of quality. So they're saying that, look, this is not only important to us for Medicare purposes, but also for commercial health plans, as well as the part of the district program in New York State, so for Medicaid as well. We want to maximize all the value-based care incentives we can get. Other clients are Mid-Michigan, which is University of Michigan's part of that, and then some smaller hospitals. So it's not just the larger health systems, but we have a number of hospitals in the 100 to 300 bed range as well. Within PQRS, which is now evolved to MIPS, we have again Mount Sinai, which is a large health system. We submitted PQRS measures for some of their eligible clinicians last year, and they are a 3,500. They have 3,500 providers, but 2,400 of those are employed, and the 1,100 are affiliated providers. And then for just skipping one line around PQRS, a number of smaller clients as well. So clients ranging from 100 beds, 75 to 100 beds to very large health systems. Medicaid reform is somewhere we also excel at, and we have the lion's market share in Medicaid reform and DISREP in New York State. And there, all three competencies come into, they are leveraged. Data aggregation from multiple partners, measures calculation reporting, and population health, and creating risk packages that can be leveraged by care coordination or care management. I want to point out one of them, which is Finger Lakes. Finger Lakes is in the southern part of the state, of which URMC is part of, and there are two more hospitals that are part of that too. So Finger Lakes is also building a coalition of health systems around it, or hospitals around it, hospitals, ambulatory care providers, subacute care, long-term care providers that come together as a coalition so that they can deliver, much better quality of care as well as cost-effective care in their community. Then doing work around hospital-based analytics too. For example, with one of the health systems in Staten Island, we're working around a composite measure of quality and a composite measure of cost by provider, so that they can rank the providers, with quality and cost. On the partner side, HealthCurve obviously at the top, and then we have Haney's Hospital Association of New York, Montana Hospital Association, number of HIEs or RIOs in New York State as part of the DISREP program. All the measures Mark is going to talk about are certified by the ONC, both on the hospital side and the ambulatory care side, as well as we partnered with the NCQA as a pilot for the eHEDIS. We also sponsor the National MACRA Advisory Council of leaders throughout the country. For example, Dr. Bell is the former acting deputy of the Office of the National Coordinator. Mr. Munz was Chief of Staff in CIO ONC. D. Cantrell, for example, I'm just picking a few names, was Georgia CIO of the Year. And Sri Bhardwaj is from Irvine. And just a whole, well-rounded team of physicians, of IT professionals, information technology professionals that help us guide how we position ourselves and how we improve the quality of care and optimize costs in this age of value-based care. So switching to MIPS now, what are the key challenges with MIPS? As MIPS and PQRS MIPS, I think the big challenge that we've seen within our client base is re-engineering workflows for data capture and reporting. So that becomes collection of data, making sure the workflows exist to collect the data becomes critical. Training the staff so far has been used to a fee-for-service model, capturing everything. Now, as we transition to a value-based care model, that's a mind shift for the staff. So training clinical and administrative staff towards MIPS and especially MACRA as well. Calculating reporting on measures, making sure that the providers understand that they have to enter the data. First of all, they have the ability to enter the data, so the workflow is modified. Then there is a need to enter the data as well, and then tracking performance of the providers, doing comparative providers. Eligible clinicians respond best to if you show them how they're doing vis-a-vis their peers. So demonstrating how they're doing as compared to their peers, and not only looking at MIPS, but also looking at clinically integrated networks, looking at other risk-based or value-based contracts that may be available to the health system to work on, and then developing an entire process. We have a survey.
Thanks, Dr. Lockenthal. So we're going to take a moment to conduct our first survey. What is your biggest challenge with the upcoming transition to MIPS? I'm going to launch the poll and give everyone about 45 seconds to answer it. You know what? I apologize. It looks like I accidentally closed the poll right after I opened it. So I don't think I can launch it again. So what we're going to do is we're just going to move on, and then we'll conduct the second poll when we come to it.
So who's eligible? For the 2017 reporting period, all physicians are eligible, and there are certain ones that are not. PAs, nurse practitioners, clinical nurse specialist, and CR. CS estimates that out of 1.3 million eligible clinicians, as we're called, 600,000 are MIPS eligible. Now, for 2017, not are clinicians that are enrolled in Medicare, right out of residency in the first year. The ones that are participating in APMs, so MSSP, Medicare Shared Savings Program tracks 2 and 3, and they have a low volume threshold. So if they are doing less than $30,000 in annual Medicare billings, or see less than 100 patients a year for Medicare, then they're not eligible. Just want to complicate this a little bit, that there's a proposed rule out there that says that the number of the dollar amount will go up for 2018 reporting, not for 2017. For 2014 reporting, it'll go up to $90,000, and those that are not eligible will, the ones that see less than 200 patients will not be eligible. So the threshold will go up in 2018, but in 2017 the threshold remains the same. Just while I'm on the subject of the proposed rule, they're also looking at not at the hospital level, but for smaller practices outside the health system, less than 10 providers. They're saying that they could form also virtual groups. So those are three main things. Another thing that may impact you is another, rule, a proposed rule that may impact you. One of the components is that hospital-based physicians may be rolled into a hospital value-based program. So those are things that could impact this for 2018 reporting, but none of them impact it for 2017 reporting. But keep in mind, I want to emphasize this point, that in all the proposed rules, they're saying for next year, health systems or eligible clinicians will have to report for the entire year. So it's not, this year we're doing tracks, and I'll come to that in a minute, but next year, health systems will have to report for the entire year, or the eligible clinicians will have to report for the entire year. Payment adjustments this year still 4% positive or 4% negative, based on how you perform, and we'll talk of that in a minute. Next year, in the proposed rule and today's rule, it is plus minus 5%, going to plus minus 9% in 2022. And then advanced APMs, they earn 5% lump sum in incentive payments each year, and they avoid MIPS reporting requirements. So that'll be, I have a slide on that. So MIPS performance categories. There are 4 categories. Quality is by far the dominant category. It's 60%. Clinical practice improvement activities is 15%. advancing care information is 25%, and cost was 10% last year, but based on feedback, it's 0%. Here again, I want to add the proposed rule to this. In the proposed rule, and I hope I'm not confusing you, but I wanted to present the proposed rule as well. In the proposed rule, cost is 0% next year too. So just as an FYI, and quality will remain 60%. So quality replaces the old PQRS. Clinical practice improvement activities is new activities. There are 92 activities. You need to do 4 of those. And then advancing care information is 5 essential activities. If I can remember them, meaningful use is one of them. Prescribing is another. Integration with HIE is another. Having a patient portal is another. And then doing a security and risk assessment is the 5th one. So, and then cost is the 4th category. Cost goes in the proposed rule for next year. Cost is not there, but all of the hospital-based, value-based purchasing is based on quality and cost. So I think cost will keep on becoming more and more important as we advance. So what are your options for this year, 2017? There are 4 options. One is testing the payment program. So you can say, if you have not yet selected a vendor, if you have not yet decided what you do, you say, I'm going to take test option 1. I'm going to take option 1, and I'm going to submit some data. And that avoids the 4% penalty that you may be subject to. Avoids the negative payment adjustment, and need to report and achieve 3 points. And that's where you report 1 measure or 1 clinical practice improvement. Simple thing to do. If there is 1 take home, please do that. Second option is participate in the program. For that, you need to submit 90 days worth of data, submit comprehensive data for 90 days, allows for a small positive adjustment. Option 3 is participate for the whole year. And there you submit for a whole year, allows for a moderate positive payment adjustment. And I think that's where it's going to stop. To be on the safe side, there is a risk of negative adjustment too. And 4th is do an advanced APM. So Medicare Shared Saving Program, track 2 or 3, and that allows for a 5% positive adjustment. So again, as I mentioned, if you do nothing, make sure you take option 1 so that you're submitting some data and there is no question that you will be penalized. 4% of your Medicare Part reimbursement can be a lot of money. Keep in mind, next year you'll have to be even in the proposed rule, you'll have to submit for the whole year. So it'll be good to be prepared this year or next year. We wanted to spend a minute on the cost as well. Cost typically is, the way to understand cost is we can help you with that very clearly, but to get your QR/UR reports, take your QR/UR reports and understand what your costs are compared to other eligible clinicians. So clinicians are assessed on Medicare claims data. CMS will provide feedback for how a clinician performed in this category in 2017. So that'll be in late 2018. For next year, CMS is saying, we'll give you another year to understand your costs before we implement in 2019. So, and this is the proposed rule, not the rule that's today. So the way it works is there's a proposed rule, there's a time period to provide comments, and then CMS finalizes. So the ultimate goal of CMS is to align cost measures with the quality of care so that there's a better patient outcomes or improved patient outcomes and smarter spending become a pursuit together. Here is what a timeline we propose. And, at least with the clients we're working on with today, we're saying today is a time when they're all selecting measures, or they've selected measures that they plan to report on for 2017. We think it's a journey. So they're saying, okay, we're going to report these for 2017. The same measures we might report for 2018, but also we might not. At least 80% will report the same measures for 2018. They're rationalizing these measures with other programs they might have in place. Pay for performance incentive programs with various health plans. Mount Sinai has 5 or 6 pay for performance programs with various health plans. Or at-risk programs they may be. They're, again, taking Mount Sinai as an example, they have, I believe, 2 or 3 ACOs as well. So also what measures there, so that there's consistency in the measures they're reporting. This is critical. As you select the measures, you may find that you don't have the data for some of the measures. So ensure data readiness. Ensure that you have workflows to capture the data, and ensure that the physicians are not dictating the results so that you don't have data available in a structured format. Or if it's still in an unstructured format, there's a way to get it out. So there are multiple hoops there that you may have to jump through to ensure that the measures you've selected can be optimally submitted to CMS in terms of getting high scores. Pick a track. So for this year, you say, based on the measures, based on the data availability, you may pick track 1, 2, or 3, but definitely pick track 1. Definitely the least you should do is pick track 1. And then validate results of submission. That'll happen, whenever you submit the data, we'll turn it around in 6 to 8 weeks, validate results of submission, and then March 31st is the submission deadline. But now the journey starts. Next year, you'll have to report for the entire year. Further improve clinical processes. You may decide to drop some measures, add some measures. You may decide to improve workflows so you can get more data on the measures. You may decide that, you could flu shots, for example. You did very well on flu shots. You could have a pay for performance program with a health plan around flu shots or HbA1cs. You could do that. And then you prepare for the entire year of reporting. The way we're set up right now is we provide monthly portal refreshes, as we call them, so that your providers can get an update every month on how they're doing, and then improve performance, review costs. Next year is a great opportunity for you to review costs, improve costs, and work on that. There is a reputational impact. As it stands today, CMS will be reporting all the MIPS scores publicly, so that will have an impact on your institute as well. Talking about advanced APMs, I think one of the subsequent presentations will talk in detail about APMs. So using certified EHR, and then you have to use certified AHER. These are the requirements. Provide payment for services based on quality measures comparable to MIPS. And then be a medical home, expanded under the CMS Center Authority, or require providers to bear more than nominal risk. And here are the examples. So the MSSP Shared Savings Track 2 or 3, that's part of it. The next generation ACO models, plus comprehensive end-stage renal disease. That's for end-stage renal disease care, and then oncology care model. These are the advanced APMs. We'll touch on them in one of the subsequent presentations. So we'll talk in detail about them. Then right now, as it stands today, comprehensive joint replacement is there, and Vermont Medicare ACO initiative is part of that. That completes my part of the presentation. Very happy to answer any questions you might have afterwards. So now is the next survey question.
Thank you, Dr. Lockenball. So I'm going to launch the second survey question. Try not to close it before people have a chance to answer it. How is your organization implementing or planning to implement MIPS? Give everyone about 45 seconds. Okay, thanks everyone. I'm going to close the poll and share the results. The GPR reporting via the CMS web interface is the highest response, followed by utilizing REHR. And many of you seem to be still working on a strategy, and 17% of you are utilizing an outside resource. Thanks everyone for participating. I'm going to move along here, and I'm going to pass it over to Mark Bryant.
Great. Thank you, Nathan. And again, thank you, HealthCurve Analytics, for this opportunity to present today and to be partnered with your organization. Really appreciate it. So for my section today, I'm going to discuss how we can support your initiatives as you move into macro underneath MIPS and alternative payment models as well. And so before we get started into that section, we just wanted to give some guidance from our perspective on how to best get prepared to jump into MIPS. And the first piece of advice that we have is make sure that you get together a team, both from that represent your quality, IT, finance, clinical teams. Get together, get educated on what the requirements are, and get involved to start moving forward together, so everyone's on the same page and collaborating on how to best pick measures and how to best maximize your performance going forward. The next is take a MIPS assessment, is what we call a readiness assessment. I'll describe our process, but for you in general is understand what measures you're looking at, understand what data might be available for those measures, how does that affect your provider roster in choosing the measures before you just pick measures and start to try to advance. Make sure you have a plan around them for that. And one way you can do it is to optimize your results and understand your results from PQRS from last year, since those are make up a majority of the scoring for this year. The fourth point here is, even if you're reporting as a group reporting and not individual, it's crucial for you to understand how your clinicians are performing. So even if as a group, make sure you have the ability to drill down and see which clinicians are performing well to the measures you're chosen, and more importantly, which are underperforming, so you can truly do performance improvement. And then the last is, as Dr. Lockenpala said, even though cost isn't part of the equation for this year and potentially next, start to get ahead of that, because it'll not only affect MIPS but other value-based care programs your hospital, your health system, your provider organization might be part of. And so how do we support MIPS? First, for the quality section, we can support all the MIPS measures, and I'll talk through which measures they are. We can support, we're both a qualified registry and a qualified clinical data registry as well. And we have proven PQRS experience, as Dr. Lockenpala stated earlier. The second and third categories, improvement activities and advancing care. We can, as a qualified registry and a QCDR, we have the means, CMS's approval to submit on these categories. We can cover all quality improvement activities and advancing care as a submission, and we can also provide you one portal, one place to track these measures and these activities on an ongoing basis. And I'll show you a little bit of our demo to come. And then the last is we can provide cost and utilization analytics as well to help you get ahead of the curve. And so our measure platform, as Dr. Lockenpala stated, we're ONC certified for all hospital electronic clinical quality measures, all 29. So today we are supporting reporting for hospital and patient quality reporting, meaningful use, and for the Joint Commission as well. On the ambulatory side, we're certified for all 64 ECQMs. So there's 53 that CMS has allowed to report on for MIPS this year. So we can handle electronic clinical quality measures. But like I stated, we're also a QCDR and a qualified registry, and there's 243 measures that we could support for reporting there. And we also have a full library of measures supporting clinically integrated networks, accountable care organizations, Medicaid reform in New York and other states, which are HEDIS-based measures. We could also support, CPC Plus, patients at our medical home, and other programs too. So we can give you a full line of a solution to cover multiple programs and multiple measures across your hospital and health system, both on the acute side and ambulatory. Our platform has been, as I talked about, being the certifications externally, but the first step is validation internally. So we have a team of business analysts that look at every program. They look at the measure specs that are published either by CMS or NCQA or a different regulatory body. They build those measures. It goes through a quality assurance process prior to becoming live for our clients. And every year these measures are reviewed. Measure specs change. They're upgraded for our clients. So we handle all the back-end building, certifying, testing of those measures. And then externally, as I said, we're ONC certified, qualified registry. And then the last point is we're going through HEDIS certification right now at NCQA on our library there. And so one of the biggest questions that's always asked is, how do you access data? How do you get data, acquire data, integrate data for misreporting and other quality programs as well? And there's a bunch of different strategies as data sources and adoption to EHRs, and how you're capturing data in your workflow varies from hospital to hospital. And so we try to be as flexible as we can in our approach. The first thing that we can do for MIPS is take in billing data, your 837 professional that's going to your clearinghouse today. We can utilize that 837P to calculate the measures and provide smart web forms where there might be quality data codes missing. We can also leverage clinical data, and we can leverage clinical data as structured formats, QRDA, CCDA, feeds from your EHR. We can provide custom reports specifications, so we'll tell you what data elements that we need and work with you to pull custom reports from EHR, and we can also build interfaces into your EHRs to extract the data directly that we need to calculate the measures. So once we have the measures, they go through our measure framework, they go through that library of measures depending on which ones are applicable to your needs. We'll provide dashboards, and I'll show you a glimpse of that in a second, and we handle all the submission, and I'll talk through that again in a second too, to satisfy MIPS, but we can also handle satisfy ACO requirements, and we can support other initiatives as well. If you're part of a clinically integrated network, if your providers are part of a TCPI grant, we can help in those areas too. And so how do we report? So first is a qualified registry. Again, there's 243 measures that you could select from, and we handle the submission as directly to CMS as an XML file or a direct submission via API. For qualified clinical data registry, again, it's 243 measures, but we've also been certified by CMS to report 5 non-standard MIPS measures that are behavioral health in nature. We can also support electronic clinical quality measures as a QCDR, and we can submit directly to CMS. And in the last category, as a certified EHR technology, we can support ECQM reporting again, and that's in a submission format of QRDA3 that we would create and send off to CMS. And then the last category I wanted to talk through before we get into a demo is on advanced payment models, or alternative payment models, excuse me. And so this is our population health side of our solution. We're doing a lot of this analytics today, and for our clients underneath Medicaid reform, where we're creating risk stratifying the patients or their members in the population, creating longitudinal patient history, doing flagging, disease registries, geomapping and hotspotting, and giving them a perspective, and we can give them an ACO perspective of what's your member population and who's at high risk for cost, who's at high risk for utilization, who's going to, potentially end up back in your ED or inpatient, and help you try to coordinate care for them before they're back into your hospital for that. I'm happy to talk more about that separately, and as Dr. Lockenpot stated, we'll hold a separate webinar just on alternative payment models down in the future. And so as I go into the portal, everything that we do is user-based. For our solutions that we offer our clients, an executive role, be able to look at your organization, whether you're, for MIPS reporting, it's done by tax identification number or TIN. So whether you have one TIN or multiple TINs, we'll be able to see performance across those, be able to see, which measures you're tracking, be able to drill down into them and see performance by clinicians, what's driving, what's trending, customizations there. The analyst role or quality coordinator or informaticist, whatever that title might be in your organization, they take it one step further from the executive level and are able to drill down into patient level details. So they have PHI access, whereas the executives don't. We try to section that off for our clients based on their needs and who should have PHI and who shouldn't. Tied to an analyst is a submitter role. What this means, and it could be the same role as an analyst, it could be the same person as the analyst, but prior to submission, if you're tracking more than the required measures, so for instance, for quality, you have to report on 6 quality measures for track 2 and track 3 of MIPS. We tend to recommend to our clients to track 10 or 12 measures to give you a pool of measures that prior to submission you can look at and see which ones are performing the best. So that submitter would have access to look at those measures, pick the ones that are performing best, and then create a report to us that we send off to CMS. And we can also provide a provider role or clinician role where they can log in and see gaps in care as well. So let me go to our portal real quick. So again, this is based on user access. If you're managing multiple TINs, multiple tax identifications, multiple practices underneath your organization, you'd have a login screen where you can see performance across these TINs. Give you a performance period is 2017, but as we build a relationship, you'll be able to build upon these years and go back in the past and do comparisons. We can show you by quarters. So depending on how you're submitting, if you're submitting on all data for the full year, you're going to want to see an all quarters look. If you're submitting by 90 days, you can come in and select the quarter you wish to view and see which quarter is performing the best. And then you have a quick overview up top where we can show you potential earnings, maximum potential earnings across your TINs, and then a list of the TINs and how they're currently performing. And that's all based on a composite score. Everything is color-coded in our system, meaning if you're outperforming, it's in green. If you're underperforming a level, it's in orange. If you're underperforming multiple levels, it's in red. And that benchmarking is specific to each program and in this case in MIPS, to each category underneath it. And I'll show you that in a second. But you can quickly see which TINs are performing well and which are underperforming slightly and which are at potential risk because there's no data, they're not performing well, whatever the circumstance might be. So let me click on one real quick. Crossroads Hospital is a TIN, and what this look is going to look at Crossroads as if they're reporting as a group. We can also show a look that's reporting as an individual clinician. The difference is you'd log in first and see the list of individual clinicians, then be able to pick one, and you get the same screen where you're going to see for Crossroads what's their current composite score for this TIN, how are they currently doing across each of the categories, and then here's a look at each of the categories: quality, advancing care, and improvement activities. So we'd work with you to understand to help you in the selection of each of these categories, build out the portal, and then give you the means to track this on an ongoing basis. If just looking at quality for this purposes, you'd have a list of those measures that you're tracking. We give indicators that show if a measure or lower rate is desirable, which measures are outcome measures because you have to report on at least one outcome measure. And then the quality measures, the benchmarking for them is based on the deciles that CMS has published. So we're going to show you at the point in time how each of your measures are doing compared to those deciles. So there's, if you show any performance, you're in the 3rd decile. The key is to get up to the 10th decile to maximize your score. So in this case, this measure is performing at the 10th decile. This measure, preventive care and screening, is performing in the 6th decile, so you're getting 6 out of the 10 points. Falls plan of care, you don't have any data as of now for that, so that one has a 0, and it's shown in red. And then some measures don't have deciles published this year, so showing any performance, you get 3 points, so we indicate that in blue, just as long as you show some performance. And then from here, you'll be able to drill down, and we have customization for you to show you trending for this measure, to show you what's driving the measure performance, how many are in the denominator, how many exclusions, how many in numerator. And then, like I said earlier, even though you're reporting as group here, it's crucial to see performance by provider. So you can see who's performing well to this, that's attributed to this measure, and who is underperforming. So you can work with these providers to figure out, is it a workflow issue, what's causing them to underperform to this quality measure. And I'm going to flip over to the analyst role. So the analyst role that won't have the composite score up front, like the executive will. The analyst is going to get into the meat of the information. So they're going to have the quality performance category, advancing care, improvement activities. They're going to be able to see at this point in time how each of these are doing. So if we, again, just look at the quality, they'll be able to see, for diabetes, hemoglobin, A1C for control, how many are in the numerator, what's the performance met, what's the performance rate, and what's your current score, what decile do you currently sit in. And then they can start to drill down onto this to see patient-level details. So they can see what's making up these, who's in the denominator, where performance wasn't met. So they can say, okay, for these patients, performance was met for patient Lee. Performance was not met for, patient Jones, and why. And then if there's any data missing. So in this case, this is an example where we'd be using billing data. So we can give a smart web form here where if they click edit, they can come in and pick the right QDC code or G code, whichever you want to call it, pick the right code, populate it, come down here, click submit, and now this will be updated for that code that was previously missing. We then go through a validation process on our backside back end to make sure that that's correct, and then it becomes live for that. So that's a quick sample. There's some other features in here around financial scorecarding, around the other categories we can show you separately, but I just wanted to give you a little viewpoint of what we're offering for this. And so up in 1 second here. Bear with me. Back in. So I'm going to talk through in a second our readiness assessment process for this.